Hello, my name is Ariel Charles. I'm a PGY1 pharmacy resident at Erlanger Health System in Chattanooga, Tennessee. Today I will be presenting my research on the effectiveness of an antibiotic treatment protocol in the management of community-acquired pneumonia in pediatric patients at an academic pediatric hospital. The authors of this investigation have no disclosures they'd like to communicate at this time. A little bit of background information. Pediatric Infectious Disease Society and the IDSA recommend that for community-acquired pneumonia, patients who are fully immunized receive amoxicillin or ampicillin, patients who are not fully immunized receive ceftonir or ceftriaxone, and patients with a severe allergy to penicillins receive clindamycin for the treatment of their pneumonia. Despite this recommendation, many patients who are fully immunized are given some type of alternative antibiotic. Evidence has shown that using a protocol increases adherence to guideline-recommended therapy. This investigation took place at Children's Hospital at Erlanger. It is the area's only comprehensive regional pediatric center with a level 4 neonatal intensive care unit. It's the region's only teaching children's hospital and has the region's only pediatric emergency department. The purpose of this investigation was to evaluate appropriate antibiotic selection for pediatric community-acquired pneumonia, or CAP, patients after implementation of a guideline-driven treatment protocol. The primary outcome was to compare antibiotic therapy selection in pediatric patients with suspected CAP before and after protocol implementation. The secondary outcomes included the assessment of occurrence of the appropriate treatment selection and appropriate dosing, penicillin allergies, immunization status, average duration of therapy. This was a retrospective institutional review board approved single center study looking at 2 respiratory seasons in 2018 and 2019. In October of 2019, a CAP order panel was implemented and data was collected via chart review. Patients were included in this study if they received antibiotics or a prescription for antibiotics for community-acquired pneumonia in the emergency department and were between ages 60 days old but less than 17 years old, or 18 years old, sorry. Patients were excluded in this study if they were immunodeficient, had an increased risk of aspiration pneumonia, had cancer, a known lung disease, prior or current tracheostomy, or a lung abscess or empyema. In the pre-protocol group, there were 264 patients. 56 were included, leaving 208 patients to be enrolled in the study. In the post-protocol group, there were 268 patients. 50 of those patients were excluded, and there were 218 patients enrolled. A chi-square test and a Mann-Whitney U test were used for statistical analysis of the data. 80% power required 55 patients to be in each group of the study. Baseline demographics collected for this investigation included gender, patient age, immunization status, penicillin allergies, and whether or not they used antibiotics within a 14-day period prior to their visit to the emergency department. The pre- and post-protocol groups were relatively similar. For the primary outcome of the study, there was an increased use of amoxicillin and decreased use of cephalosporins as well as azithromycin. The increased use in amoxicillin and the decrease in azithromycin were both statistically significant. For secondary outcomes, the appropriateness of antibiotic selection increased in the post-protocol group and was statistically significant, as well as the amount of patients who were considered fully immunized. 14-day readmissions and the duration of therapy for treatment stayed about the same for both pre- and post-protocol groups. So we saw statistically significant increases in amoxicillin use as well as in statistically significant increases in appropriate antibiotic selection. Statistically significant decreases in azithromycin were also seen, and clinically significant decreases in cephalosporin usage were also seen in this investigation. The limitations of this study include that it was a single-center study and it was limited to 2 respiratory seasons. There was no data collected about sputum cultures, and the accuracy of the diagnosis of bacterial pneumonia was not assessed. The 14-day readmissions were also limited to this single study and did not include any visits to any outpatient clinics or urgent cares. The strengths of this study include the large sample size and that the study did meet 80% power. This study also used evidence-based recommendations. In conclusion, the introduction of an order panel was effective in guiding appropriate antibiotic selection. Statistically significant increases in guideline recommended therapy for fully immunized patients were seen, and clinically relevant decreases in cephalosporin and macrolide use were also seen. For the next part of this project, there will be a quality improvement project instituted at the hospital this spring. Future studies could consider the accuracy of diagnosis and the role antibiotics would play in a patient with a positive viral panel. These are my acknowledgments and my self-assessment question. What antibiotic is indicated for a suspected CAP in fully immunized pediatric patients? The correct answer is amoxicillin. That concludes my presentation. Please do not hesitate to reach out at the email listed below if you have any questions. Thank you for your time.